Dr. Vijayakumar, respected chairpersons, Dr. Shruti, senior doctors, my doctor friends. I'm here to make a presentation on elevating diabetes care time and range optimization with second generation basal insulin with a particular focus on evidence-based findings. I thank Dr. G. Vijayakumar for his kind invitation. Also thank Sanofi for including me as one of the speaker for this particular program, duality of interest declaration. Of course, this is an industry-supported symposium. What I'm going to do another 15 minutes. I'm going to make a presentation. So I'm sure all are aware of the fact that type 2 diabetes mellitus in patients with type 2 diabetes, intensive glucose control, if initiated immediately after the diagnosis, is a well-known fact to be effective in preventing long-term diabetes-related complications. However, the intrinsic control increases the risk of hypoglycemia, and severe hypoglycemia has been cited as the important reason for adverse treatment outcome, cardiovascular morbidity, mortality. It also reduces the quality of life. So, achieving favorable glycemic control, reducing the risk of hypoglycemia are regarded as important measure for treatment. Yet another important parameter, glycemic variability, which is a common challenge for patients with the diabetes. So, excessive glycemic variability and suboptimal TR can significantly impact the lives of patients with the diabetes. So, it's an important surrogate marker for vascular complications, and international guidelines recommend TIR and glycemic variability as key metrics to facilitate effective diabetes management. So, beyond A1C, we need to focus our attention on glycemic variability, variation with reference to plasma glucose level, which may increase the risk of hypo as well as hyper. So time in range, a new metric in diabetes management, that is the amount of time patients spend with a specific blood glucose in the range of 70 to 180 milligram. So a patient with the diabetes should spend at least 17 hours a day, that is more than 70% of 24 hours, with a plasma glucose range of 70 to 180 milligram. So what are the components? We have time in range, keeping the A1C 70 to 180. We have time above range, level 1, 180 to 250, level 2, more than 250. And next is time below range, that is between up to 70, that is level 1. Less than 54, we call it level 2, time below range. So our aim is to increase the patient's TIR, minimizing TBR, and reducing the time below range. So beyond A1C, time in range and glucose variability in the context of CGM. For patient prone to glycemic variability, especially patient with the type 1 or type 2 with a severe insulin deficiency, glycemic control is best evaluated by the combination results from A1C, fasting plasma glucose, postprandial, SMBG, like that. So A1C has limitations. It provides a single level, gives values 3 months apart, does not represent glycemic variability, and less likely to show impact of acute treatment. Next is TIR, that is, it evaluates continuous glucose monitoring levels, may compare the fluctuations at any given point of time, show glycemic variation as well as differentiate between time below range, time in range, as well as time above range, and likely to show impact of acute treatment. So these two patients, upper panel, lower panel, two patients having similar A1C, but if you look into the graph that shows wide variations, wide fluctuations, glycemic variability, which may increase the risk of hypo, which may increase the risk of hyperglycemia. SMBG does not give full picture. It provides a single that is point in time measurement, fail to detect glucose variability, and may miss nocturnal and symptomatic hypoglycemia, but at the same time, it is invasive and painful. And see this graph, upper panel and lower panel. Patient recorded SMBG, that is, it clearly shows time in range. But see, the patients put on continuous glucose monitoring. You can see range of hypoglycemia, that is below range, time in range, as well as above range. That's how CGM is very important measure for assessing glycemic control compared to SMBG. So suboptimal TR can have substantial negative impact on the lives of patients with diabetes. Each 10% decrease in TIR was associated with increased risk of retinopathy by 64%, neuropathy by 25%, microalbuminuria by 40%. So increased mortality in patient with the type 2 diabetes. That is 5% increased risk of cardiovascular mortality and 8% increased risk of all-cause mortality. So 10% decrease. For example, from 70% of the day, TIR less than 10, 60%, it translates into high all-cause mortality as well as risk of diabetes-related complications. So evidence to the benefit of CGM. CGM comparison trials. So CGM lowered A1C levels, reduced the need for blood glucose monitoring, reduced the time in hypoglycemia, also improved the time spent in target range. So positioning in time in range in the treatment of patients with the diabetes in India. Indication for TIR in patient with the type 1 to assess insulin requirement to titrate insulin. Patient with the type 1 CGMS that will minimize the period of hypoglycemia, it improves glycemic control. Next is overall the quality of life will also get improved. Next is type 2 diabetes. To those, that is to choose and monitor diet. Next is to observe the impact of exercise to optimize OAD and insulin dose. So depending upon the patient profiles, that is OAD inadequacy or patient with gestation diabetes or hypoglycemia or managed diet and lifestyle and pre and post hospitalization. So patient with the type 2 diabetes, we can assess whether the patient is strictly adherent to the medical nutrition program or whether the patient follows the improvement with reference to physical activity, whether the patient is adherent to the oral anti-diabetic drugs. So recommended frequency for repeating CGM and TAR assessment in patient with the type 2 diabetes in South Asia. If the patient is able to maintain TIR more than 90%, we can do CGMS, we can do this continuous glucose monitoring assessment once in 6 months. Next is TIR greater than 70% once in 3 months and TIR less than 50% once in 3 months. So the international consensus TIR does not have recommendations on frequency to repeat the test. In type 1 and pregnancy, it is always recommended to have continuous use of CGM if the resource is adequate. In majority of patients with the type 2 in South Asia, continuous use of CGM may not be feasible, right? So the treating physician can make individualized clinical decisions. Glycemic variability associated with the peaks and trough caused by glycemic excursion post-meal and caused by hypoglycemia during interprandial period. So basal insulin glargine effectively control the PPG excursions by hitting the base of the fasting. That is fasting first. Next is lesser risk with glargine compared to NPH, lesser risk with glargine versus premix or co-formulations. So the high glycemic variability is associated with the development and progression of diabetic vascular complications, the exacerbation of hypoglycemic risk and deterioration of patient quality of life. Hence, minimizing glycemic variability can prevent future cardiovascular events. Next is evaluation of basal insulin development. So basal insulins have been developed to provide a very good basal insulin coverage with less peak and trough ratio, minimizing the risk of hyperglycemia and improving the glycemic status. So we have the time-tested molecule, glargine 100IU, that we have been using it commonly for many decades, more than 2 decades. Next came the ultra-long-acting basal insulin analog, second generation insulin glargine 300IU, as well as insulin degludec. They are characterized by less peak to trough ratio in terms of pharmacokinetic. They offer even a flatter and constant PK and PD profile compared to the first generation of basal insulin analog or the human NPH insulin. Next is glargine 300 versus glargine 100IU. What are the differences with reference to mechanism of action? We know glargine 100IU, when it is injected in the subcutaneous tissue, it gets absorbed to mediate the pharmacokinetic and dynamic profile. Glargine 100IU, it contains 300 units per ml. So the volume is less when it is injected in the subcutaneous tissue. So the size is very small. It has a compact structure. The size and the surface area, it has been hypothesized that both the size and the surface area, that determines about the resolution date. Next is increasing the concentration, that is 300IU per ml. Increasing the hexameric formulation, that alters the diffusion, that is the diffusion and millimole ratio by increasing the proportion of hexameric insulin injection depot. So it reduces the diffusion area and the millimole ratio, thereby it shifts the pharmacokinetic and pharmacodynamic profile to the left side. Thereby, it improves the glycemic control, minimizes the risk of hyperglycemia. The dissociation of insulin occurs from the surface area of the injection depot, predicting that the decrease in the diffusion area per millimole ratio, it would affect the PK and PD profile. So time for change, time in range. So 2012, target range defined. Next is 2017, systematic approaches to the CGM data evaluation. In the 2023 ADA, CGM should be considered to improve the glycemic outcomes and decrease the glucose variability. So Glordin 300 IU trials using CGM or TIR in patient with the type 1 as well as in patient with type 2. So type 1 diabetes demonstrating lower variability with the Glordin 300 IU versus IDEG with 24 hours euglycemic clamps. So patient with the type 1. This particular study was conducted with both IDEG 100 IU as well as Glordin 100 IU. So drug naive, that is Glordin and IDEG with individual clinical doses of Glordin 300 as well as IDEG. After 3 months of optimal titration of basal insulin, there was 23% greater insulin peak with IDEG 100 compared to Glordin 300 IU and 22% lesser within the variability with the Glordin 300 IU versus IDEG 100 IU. Next is Glordin 300 compared to IDEG, flatter curve PK and more stable glucose lowering effect. So it provides lower within the variability, more evenly distributed pharmacokinetic profile compared to IDEG 100 in once daily morning dosing regimen of 0.4 units per kg body weight. This particular trial demonstrated 20% lesser within day variability with the Glordin 300 IU and IDEG. So it produces overall more even than insulin declared PK profiles. And the study demonstrated that Glordin 300 has characteristics suitable for use as once daily basal insulin with more evenly distributed PK profiles than IDEG 100 IU. So less fluctuating steady state pharmacodynamic profile and more evenly distributed pharmacokinetic profile. So basal insulin Glordin 100 IU versus IDEG using this flash glucose monitoring in patients with the type 2 diabetes. The endpoints TIR and TBR less than 70 milligram, and TIR TBR less than 70 milligram and TBR less than 54 milligram. So Glordin 300 IU in basal plus demonstrated better TIR, number 2, reduced risk of hypoglycemia and reduced risk of nocturnal hypoglycemia by 18 times. Next is in-range study design. During the titration period, doses of Glordin 300 IU or IDEG were titrated to achieve the target fasting plasma glucose. While avoiding hypoglycemia, basal insulin was titrated at least weekly and no more than every 3 days. So in-range study results, main primary and second endpoints with reference to TIR and coefficient of variability. Primary endpoint and first main second endpoint. In-range study had successfully achieved its endpoint non-inferiority of Glordin 300 to IDEG in terms of TIR and percentage of coefficient of variation. So in-range study results efficacy. Second endpoints, TIR superiority at week, that is 12. Superiority of Glordin 300 IU versus IDEG 100 on percent TIR was not demonstrated. That is you can see the graph with reference to second endpoints. So in-range study, the first RCT comparing Glordin 300 and IDEG 100 in type 1 patients during TIR as endpoint. So primary endpoint, main second endpoint, and hypoglycemia. Glordin 300 is non-inferior to IDEG 100 in patient with the type 1 with similar hypoglycemia and safety profile. Comparison of Glordin 300 versus first generation basal insulin, the CGM profile and variability, similar A1C reduction with Glordin 300 versus Glordin 100 IU. So Tugio showed better glycemic control with robust TIR. It improves TIR, reduces TAR as well as minimizes TBR. So use of Glordin 300 in special population, especially in elderly patients, based on various trials, Edition, ETOS, BRIGHT, and DELIVER. There is robust A1C reduction in patients who are elderly. Use of Glordin 300 IU in renal impairment based on addition, deliver, and bright at-house trial, effective A1C comparable A1C reduction with 10% lower risk of anytime hypo in patients treated with Claudin 300 IU. And Claudin 300 IU in pregnancy, it can be used during pregnancy if clinically indicated and clinically needed. The safety of Claudin 300 IU during pregnancy was examined using post-marketing pharmacodynamic data. So in short, glycemic variability and suboptimal TIR can significantly impact the lives of patients with diabetes, and numerous trials using CGM and TIR profiles have demonstrated that Claudin 300 provides effective and sustained glycemic control with lower incidence of glycemic variability. It allows dosing flexibility, that is up to 2 hours, 3 hours in timing injections to deal with the situational variability experienced in daily life, and use of Claudin 300 that is associated with lower incidence of overall and nocturnal hyperglycemia. Thank you very much for your kind listening.